PD-L1 is a very important biomarker, specifically when thinking about whether to use immune therapy for patients in the first-line setting. So we know from the trial of pembrolizumab versus chemotherapy in the first-line setting that in that trial, patients were selected based on a PD-L1 cutoff of 50% or greater. And that trial was very positive, with patients benefiting from the immune therapy versus chemotherapy. So in that setting, it's very important to get the PD-L1 biomarker, and I think that's very much accepted now. So I think that's a very clear area in which to use that biomarker. From there, I think it's much more difficult because the trials are variable. So PD-L1 is being tested in a variety of different ways. There's multiple different assays. There's different cut points that are being used. Some of the trials have used 1%, some have used 50%, 5%, 25%. So when you're looking at the different trials, it's really important to look at which assay is being used, which cut point is being used. Is it all comers? Is it a specific cutoff that's being used? And because of that, the data look different when you look at different trials. But overall, if you look at all of the different trials and try to come up with a comprehensive understanding of PD-L1 as a biomarker, I think generally you can say that there does seem to be an increasing benefit with immune therapy with higher levels of PD-L1 expression. However, it's also become clear that even patients without PD-L1 expression, with 0% positive cells staining for PD-L1, that they still can benefit from treatment, although less of a chance of benefit.